Calcium channel blockers are among the most versatile drugs in cardiovascular medicine. They treat hypertension, angina, arrhythmias, Raynaud's phenomenon, and even migraine. But the two major subclasses, dihydropyridines and non-dihydropyridines, have critically different pharmacology, clinical uses, and toxicity profiles. Confusing them can be dangerous. Today we break down everything you need to know. To understand calcium channel blockers, you first need to understand what L-type calcium channels do. L-type calcium channels, the long-lasting type, are voltage-gated channels found in cardiac myocytes, smooth muscle cells, and SAAV nodal cells. In vascular smooth muscle, calcium influx through L-type channels activates myosin light chain kinase, causing vasoconstriction. In cardiac myocytes, L-type channels drive the plateau of the action potential, phase 2, and trigger calcium-induced calcium release from the SR, enabling contraction. In the SA node and AV node, L-type channels are responsible for the action potential upstruct itself, since these cells lack fast sodium channels. Calcium channel blockers bind to the alpha-1 subunit of the L-type calcium channel and block calcium entry. The therapeutic effect depends entirely on which tissue has the highest density of the relevant binding site, and different drug subclasses have different tissue selectivity. The two major subclasses are dihydropyridines and non-dihydropyridines. Dihydropyridines, the ipines, include amlodipine, nifedipine, felodipine, nicardipine, and clevidipine. They preferentially bind to vascular smooth muscle L-type channels in their inactivated state. Their dominant effect is vasodilation, particularly arterial vasodilation, reducing systemic vascular resistance and blood pressure. They have minimal direct cardiac effects at therapeutic doses because cardiac channels spend less time in the inactivated state at normal heart rates. Reflex tachycardia can occur from the drop in blood pressure. This is why short-acting nifedipine is avoided. Amlodipine has a very long half-life of 30 to 50 hours, providing smooth 24-hour blood pressure control. Non-dihydropyridines include verapamil and diltiazem. These bind to both vascular and cardiac L-type channels, with significant cardiac effect. They slow SA node automaticity, slow AV nodal conduction, and reduce myocardial contractility. Their rate-slowing effect makes them invaluable for rate control in atrial fibrillation and flutter. Verapamil is the most cardioselective, maximum negative chronotropy and inotropy. Diltiazem sits between verapamil and the dihydropyridines.
Clinical indications for dihydropyridines. Hypertension, first line, especially in elderly patients and Black patients, where CCBs outperform ACE inhibitors as monotherapy. Stable angina, by reducing afterload and thus myocardial oxygen demand. Vasospastic angina, Prinzmetal's angina, where coronary vasospasm drives ischemia. Dihydropyridines directly relax coronary artery smooth muscle. Raynaud's phenomenon, reducing digital vasospasm. Nicardipine and clevidipine IV formulations are used for hypertensive emergencies requiring titratable blood pressure control. Clinical indications for non-dihydropyridines. Rate control in atrial fibrillation or flutter, particularly diltiazem IV, is commonly used in the ED. Stable angina, by reducing heart rate and contractility, decreasing oxygen demand. Diltiazem is also used for paroxysmal supraventricular tachycardia, PSVT, as it blocks the AV node reentry pathway. Hypertension, second line, particularly when rate control is also desired. Key adverse effects and contraindications. Dihydropyridines cause peripheral edema from arteriolar dilation, increasing capillary hydrostatic pressure, flushing, headache, and reflex tachycardia. The edema is dose-dependent and often improves with combining a RAS blocker, which dilates the venule as well. Non-dihydropyridines cause bradycardia, AV block, and negative inotropy. The critical contraindication is heart failure with reduced ejection fraction, where further reduction in contractility can precipitate acute decompensation. Verapamil, in particular, is strongly contraindicated in HFrEF. Never combine verapamil or diltiazem with beta blockers. Additive AV nodal blockade can cause complete heart block. Toxicology Pearl. Calcium channel blocker overdose is one of the most lethal drug overdoses. Bradycardia, hypotension, heart block, and cardiogenic shock. Treatment: high-dose insulin euglycemic therapy. Insulin at 1 unit per kilogram per hour is first line and shifts cardiac metabolism from fatty acids to glucose, improving contractility. IV calcium gluconate or chloride overcomes the channel block. Lipid emulsion therapy rescues lipophilic CCBs from cardiac tissue. Vasopressors and ECMO in refractory cases. Drug interactions. Verapamil and diltiazem inhibit CYP3A4, major source of drug interactions. They increase levels of statins, particularly simvastatin and lovastatin, cyclosporine, tacrolimus, and digoxin. Verapamil increases digoxin levels by up to 70%, a classic pharmacokinetic interaction. Subscribe to Medical Sciences Unfolded for daily deep dives into pharmacology and clinical medicine.